We thank you for attending. This has been a great reception and turnout. While we're waiting for people to come in, anybody see the newspaper today? Okay. This is our second article about this event. On Section C, front cover, above the fold. Shedding light on community health, a little bit of groundbreaking. Dr. Yeka being interviewed by Director Jeff Roldan. Have any of you seen this fellow running around with a camera? Okay. You know what's going on? Okay, we're making a documentary of this event. It's a unique opportunity. This is one of the rare, unique, maybe first of its kind opportunities in the United States, where at this level of cooperation, where we've got hospitals and group health and health departments and the multiplicity of public and private agencies and entities coming together, where we can sit in the same room at the same time and have CME and CDE credits being taught, and we're all learning together. And so we're chronicling this in a movie, and Jeff Roldan, the director of Say Ah, is here. And so you'll see him floating around and interviewing and collecting footage for a new documentary, which is the follow-up of how do you do this? How do you implement this? And so that's kind of exciting. In other words, you'll be famous. On the back of your program, you'll notice an announcement flyer basically for the St. Louis meeting, the AOSH meeting. It's on the back of your program, that black, okay? Take note of that. We invite every one of you to become a member of AOSH. I'm the president of this organization this year. And it's been a thrill to bring AOSH to my own soil. We just, it's like a dream come true to, I guess, come out of that closet and be in my own community with AOSH. So, thank you. We had, at the Vegas meeting last September, we had a really strong showing of our region of dentists and hygienists who attended the Vegas meeting. And so that was also rewarding. So St. Louis, we're gonna roll out and reveal, I guess, the movie that we're making, the documentary on how you do this. How do you engage the public? How do you engage and work with health professionals to get the message out and improve? So, with that said, we're all given a pre-test, post-test, and a review page when you came in this morning. That should have been either in your packet or you were handed that to you. We would ask that you fill that out, take the pre and post-test. If you forgot to take the pre-test, fill it out and be honest with where you were when the meeting started with those questions. And then when we're done, fill out the post-test. You will exchange this for a certificate of attendance, okay, as the conclusion of today's meeting. Also, we had distributed on all your desks a credit claimed form. This is for you to use to claim your credits. You can follow the instructions on there. With that said, we're going to move on to our next segment and to announce our next speaker, who is Dr. James Winde, a close friend of mine and a wonderful health professional here in our community. Dr. Jim Lyon graduated from Texas Tech University Health Science Center School of Medicine in 1993. He has practiced family and emergency medicine and sleep medicine. He completed a postdoctoral fellowship in sleep medicine at Stanford University Sleep Disorders Clinic under the direction of Dr. William C. Dement. I want you to know, as an aside, that's a big deal. He is the author of a text chapter, Essentials of Pediatric Neuropsychiatry, and co-authored text chapter on pediatric sleep disorders. Again, that's a big deal. He currently runs 2 large sleep labs and family sleep medicine practices in Hermiston, Oregon, and in Kennewick, Washington. He is a member of the American Academy of Sleep Medicine and the Oregon Medical Association and sits on the board of directors of the Southwest Washington Pain Management Society. I want you to help me welcome Dr. James Winde.
Hello, can you hear me? Wow, that's imposing when somebody introduces you like that. A lot of people don't know Dr. Dement, who runs Stanford, is from Walla Walla. The sleep lab there is named after his wife. KSD, Catherine Severn's Dement Sleep Lab. So the Blue Mountains are well represented in sleep. I applied in LeGrand, where Bill used to go buy beer when he was 17 at the Long Branch. That's why I got accepted. So I owe my education to alcohol. I'm a nuts and bolts kind of guy. I have not done bench research. I have not worked at large institutions as a research fellow. I was a fellow in clinical medicine, and so what we're concerned with is getting knowledge, translational medicine out to the people who we need. You all see folks like I do. We're in the room, okay, in the trenches where the rubber meets the road. Is there anything more wonderful than that beautiful, warm feeling of a good night's sleep? When you give someone a night's sleep, it is one of the most amazing gifts you can give anyone. That is something that will stay with them always. I tell people that what we can do for you is make you live 10 to 20 years longer and feel better every day. Do people have sleep problems? Ask people in your practice. When I started sleep medicine, I asked my primary care people in LeGrand. 1 in 20 said they slept well. I figured, jackpot. I'm in the right place. One of the big things that you've seen lately with the changes in medicine, and we've had some problems, the insurance companies aren't covering a lot of studies. People are really worried about where their sleep labs are going to be working. One of the biggest areas that they'll be drawing from is the people who need dental devices. How many people here do dental devices and have them paid for by insurance? Everybody drops their hand, okay. Okay, it's a hard thing to do. We live on insurance. That's everything to us. We can get Cpap paid for by any company, for any reason. If you say the word dental device and you're supposed to give them procedures, alternatives, risks, and questions, right? Alternatives, how many of them get a chance at a dental device? Well, we're changing that. Working with some people like Creekside Dental, with Lee, Stout, there's a number of other dentists that we've worked with in town here. We're starting to branch out and train people on more of the medical side and what we see and what the problems that we have as practitioners. And I've learned over the last several years working with AOSH what you guys are up against. You have the same exact problems, okay? Some are different, some are better, some are easier. I think that all doctors who can't make a living right now and are complaining about reimbursement ought to have to work in a dentist's office for a while and see what it's really like when you have to get all the money yourself and not rely on insurance. That would change their perspective drastically. The same thing, a lot of what we do is recognizing disease process, and we're going to go through some of those details. A lot of this is pediatric stuff. That's kind of the way I weighted this talk. How many people here do peds dentistry? Okay. Any pediatricians in here? It's much more exciting. Babies and stuff. So let's get started. As you remember, we sleep in 8-hour cycles, but we sleep in 90-minute chunks. You fall asleep, usually in non-REM sleep, for about 90 minutes, have a short episode of REM sleep, and then you continue on, add 4 to 5, 6 of these cycles, and you should sleep, awakening occasionally, okay, for roughly 7.2 hours in North America. That's decreasing right now because we're at 13 hours, or excuse me, about 14 hours and 1 minute of daylight today. As the daylight is longer, you sleep less. As the days get shorter, you'll sleep more. The exact timing is dependent on the sun. That's what we're tied to. So this process starts out as process S and process C. Circadian timing, light going in your eyes hit peripheral receptors in your retina that shows your brain what time it is. It gives you the longitude, the latitude, time of day, and position on the earth. 45th parallel, early spring. And that's where your brain starts. It tells you when you're going to sleep. Do you sleep well during the day if you work all night? No, because it's all tied to sunlight. You can work at night, but they call that graveyard for a reason. Double the risk of stroke, heart attack, high blood pressure, depression, divorce, you name it. Don't do that. This coming from a guy who started in sleep medicine. Process S tells you that from the time you woke up this morning, you're trying to go to sleep again. And the longer you're awake, the better you're going to go to sleep. Some people are better at this than others. The ones that are asleep right now. These areas balance until you finally fall asleep at night, and the drive, the homeostatic drive to sleep and the circadian drive both drop. You sleep, recover that wonderful, warm feeling of a good night's sleep, which somebody said, hey, 5.5 hours is great. Some people say 14. Depends on your age. How many of you have high school age kids? I'm sorry, there is no cure. They can sleep 9 to 14 hours and it's completely normal. If you're doing that and you're 50 years old, there's a problem. Some people will say, I cannot sleep. I sleep 12 hours in a night and I wake up and I am not rested. They need to come see us, okay? The other thing that I always forget about, but I wanted to tell you, talk to your sleep docs. You guys got to be working this whole program that we've set up, working with the dentists, working with anybody here is check your ego at the door. I don't care what your title is. Ego does not have any place in medicine. Okay? That's a given. If somebody wants to lord it over you or think that they're too great, find another one. You guys are professionals and should be treated exactly the same as anybody else. We're all docs here. I like this because the guy starts working at 9 o'clock. Sleep drive increases. From the more you're awake, the more you want to be asleep. Depends on how the lecture's going. Circadian drive opposes that. And so you have competing forces. Now, are they the same at all times? Interesting thing. Look when you're when your sleep drive is the highest. And your circadian drive is highest. Independently. But then, when you add the two together, you have to factor in a lot of other programs. The circadian rhythm of a human being does not just affect sleep, it affects every organ system in the body. And we can go into the endocrine system ad nauseum about when it is secreted. Within 1 hour of sleep, 90% of growth hormone is secreted in young men. Interesting. Okay? Cortisol, all the other different hormones in the body are all secreted in the morning, different times during the day, pulsatile fashions. It gets very complex. But understand that the circadian rhythm has a very broad effect on all organ systems. You're balancing that with how long you've been awake, okay? Usually about 9:30, everybody's supposed to go to bed. How many people get in bed at 9:30 and fall right to sleep? The people without children or TV. Because Game of Thrones is on, right? Getting to pediatrics, people always ask me, should children be evaluated? Yes, this is a 2002 paper in pediatrics. Let's see, I can't see very well, I don't have my glasses All children should be screened for snoring. This is a white paper. That means if you don't do it, they kill you instantly. Well, something like that. And so, this has been going on for a long time. So if a pediatrician tells you no, they don't need to be evaluated, it depends on what you see. We figured out through long, detailed research that you guys look in children's mouths. How often do you see your doctor? Once a year or only when you have to? How often do you see your dentist? Twice a year, always. That's like a rule. Okay. Can y'all see that? Texas Tech, y'all. Can everybody in the room see that? Okay. Airway anatomy and physiology. This is what you have to figure out is the reason it sounds a little bit complex and you can't get hard and fast rules is, why do you sleep? We don't know. It's kind of humbling. If you can't figure out why you sleep, then how can you make definitive statements? What are the times that you sleep? Well, that varies with age, that varies with time, that varies with circadian rhythm, that varies with all these different things. You can make generalizations about sleep, but hard, fast rules, How are you going to sleep tonight? Okay, I already know 2 things that are going to make my night tough. Okay? Is there any St. Louis Blues fans in here? Good. Okay? I'm a Chicago Blackhawks fan. It's Game 5. There you go. Okay, it's a hockey game. It's the most important thing in the world. This is Stanley Cup playoffs. For those of you who don't know what it is, I have another lecture after this so we can go into that. Okay? Our life gets in the way. Look at high school kids who need some of the most deep, detailed sleep there is. 14, 15 hours at a time. Maybe 10, 11. If you have high school age kids, they come home from school. If they're in sports or doing anything extracurricular, they're buried till midnight. They get some of the worst sleep of anyone in the United States, and yet they need the most. It's a developing brain. And now I'm going to ask you to go back even further to young children, 1 to 5 years of age, and say, how do we know they're not having brain damage from low oxygen, high carbon dioxide levels, metabolic strain on them at night? Do you ever ask your 4-year-old, hey, how you sleeping? As they crawl in bed next to you, needing a glass of water. Okay? Ask them, are they afraid of the dark? It's an interesting experiment. When you're sitting in the room, flick the light off. Are you scared? No. Why? Because you're here. Are they scared of the dark, or are they scared of being alone? You have to think like a child. There's monsters under my bed. Turn the light off so they can't see you. Problem solved. So you have a lot of different changes going on. Proprioceptors, everything in our body knows where it is and what it's doing, either consciously or unconsciously. CNS or ANS is running everything. Okay, the feedback. And in this case, we're looking at how big your airway is. Dilator muscle tone, upper airway, inspiratory drive, air suction, central breathing control, brainstem. Some of you may have been, unfortunately, to my lecture on brainstem control of breathing, which is the most boring thing in the world. Okay? Central peripheral receptors. You have to be able to put a whole human together. It's great to chop them up in little pieces, grind them up, put them in a solution, and subtract out all the pieces and say, look what we found. Unfortunately, people really don't like that. They like to stay whole and feel better every day and sleep well. That's the goal here. If we can make them live longer, even better. Most of them, except for blues fans. So look at this and say, okay, here's what's going on. Where's my airway? And and where is the balance and what's tipping it certain ways. Treating your patients without looking for a worst case scenario is foolish, and you will kill someone fairly quickly. Bill Dement, okay? He'd been around a while, knew what he was talking about. There's a lot more to obstructive sleep apnea. The differential diagnosis, not the diagnosis, but the differential diagnosis has 10 or 20 different things that you have to look at. Is it a brain tumor, central sleep apnea? Can you just hook somebody up to a home study and then throw them on an auto-set Cpap like a lot of people do? No, because you're going to miss central apneas, mixed apneas, okay? Rare stuff, kidney disease, because all this is a vascular problem. What is diabetes? Why do we do sleep studies on all people who have diabetes? Because it's a vascular disease, a microvascular disease. What is the common pathway that we all are looking at today in all this inflammatory cytokines? It happens where the rubber meets the road, right at that intimal lining. Okay? And if you're not doing this to all your patients and describing the interior lining of the artery, you're not telling them what's going on. Because they don't really understand. They think those are just tubes that carry blood. But that's where the common pathway of damage occurs in almost every arena of disease that we talk about. We have huge overlap. Children are not small adults. I think that goes without saying. Vastly different physiologies. Newborns, quiet and active sleep. If you've watched a child sleep, quiet and active don't seem to fit anything that they do. Okay? Quiet sleep becomes REM sleep, active sleep or non-REM sleep, and active sleep becomes REM. Stable at 3 to 6 months. That's from a textbook, okay? How many people have children who are stable sleep at 3 to 6 months? No, doesn't happen. Like I said, real world stuff. The airway is responding to functional airflow. You have to look at the CO2 levels and O2 levels. Will a child come in my lab with an oxygen of 79 during a sleep study? No. Kids don't desaturate until something really bad has happened, and when they have something bad happen, they crash. If you're working in the emergency room and the kid's wheezing really loud, I feel great. 2 hours later, his mom calls and says, he quit wheezing. Uh-oh. They can't generate enough air to make their lung wheeze. That's the problem. And you'll hear this with moms. They'll say, well, he used to snore, but he doesn't anymore. But he's all blue in the morning. Bad. Okay? Kids go right up to the edge, and when their oxygen starts dropping off, something really horrible has happened. So when we get a sleep study, we'll see oxygen's normal, but CO2, which we can't measure unless we do an arterial line or thread a catheter into your heart, not popular during sleep studies. Okay? We can't tell the CO2. It doesn't have a little monitor that fits on your finger. We can measure Untitled CO2. We can get rough ideas of how this is going up, but all you've got to do is figure out how many times the kid quits breathing. If you don't breathe in, you don't breathe out, and your carbon dioxide is going to go up. You got to think ahead of yourself. If they have high carbon dioxide all night, what's that going to do to a developing brain in a 4-year-old? Do we have great studies for that? We're starting to get some. But do we wait and, how do you know that Johnny wasn't going to be smarter? Well, he got into Yale. Could he got into Harvard? Okay. We don't know. It's very hard to measure all these things. How do you measure the neurocognitive function of a 4-year-old? Good luck. Okay? By how many rocks they eat? We don't have good measures. Just because we don't have good measures doesn't mean we can't start thinking about what's happening from a vascular standpoint. Pediatric airway development, there's some fascinating things that you have to look at. position of the airway, and I'm going to show you some different things about the position of the airway and why peds is so hard, and when you're putting them in the chair or when you're working on them, why you will see different changes. Okay, infant airway grows in response to airflow. Now, if you think back on the slide of the proprioceptors, everything that's all the inputs going in, where does your jaw line up? How does a child hold their head? Okay? Do they have allergies? Sticking their nose out? Do they speak with this rolling, what we call hot potato voice, where their tonsils are huge and they kind of talk like this? I do what's called the very detailed baseball Mickey Mouse test. Have them say baseball, baseball, or Mickey Mouse, Mickey Mouse. Not breathing through their airway very well. We are obligate nose breathers. If you don't breathe through your nose, you can't function. You can't breastfeed. You're in trouble. We invented formula, as was beautifully explained, a breastfed infant versus a formula-fed infant. Kids live longer, but then suddenly came out this failure to thrive. Why? Is it because of decreased airflow? There's so many different things that go on. What really does cause autism spectrum disorders? They've pointed their finger at everything. Not sleep yet. I find that very interesting, because that's would have been my first. Malformations and deformations of the airway you can recognize on sight. Pierre-Robin syndrome. Look in Smith's, malformations and deformations. Children can look anyway, small jaw. I mean, I see people all the time that I say, hey, you need my card. You don't have an airway. What you guys see is even worse. I mean, I just can't believe all the stuff I missed in my first 16 years in family medicine, not realizing what I was looking at. I figured, some palates are flat and some are really steep and some teeth go in and some teeth go out. Because we don't know, because we're doctors, and in anatomy, when they get close to the mouth, they say, that's dentist stuff. Don't look at the teeth. You think this is funny, but what is the number 2 cause of ER expense in the United States? Bounce back. Number 1, bounce backs from congestive heart failure. Number 2, chronic toothache. Okay? Spend too much money taking care of the addict and not enough doing the right thing to save the tooth or the dentition or evaluate them properly for dental care. So what do? Disproportionately larger heads. We'll get into that. What percentage of a child is head? Any mom who's delivered a baby can tell you that it's about 95%. The narrowest region is the subglottic airway, below the cricoid cartilage, way down here. What position are you going to put them in a chair? A lot of this, what we know about the pediatric airway, is from intubating children, and so it falls back to that, but it's taught us a lot about the upper airway versus the lower airway. Epiglottis is more floppy and U-shaped, so it likes to stay closed. Okay, the larynx is more anterior and cephalad, forward. Smaller tracheal length. Let's get into some pictures of that. Okay? We always see pictures like this and say, aren't children cute? To me, they're just dangerous. I have 4. Okay? You either have children, time, or money. I have none. One quarter of a child is head. Yeah. See, these guys are not all the same height. Center of gravity right here shows you. And so there's this drastic morphologic change in the child from infancy to what you would call young adult stupidity. 12. When you look at this, what's the first thing you notice about this girl? She's almost in a sniffing position. Okay? This is normal. Large, flaccid tongue. Infants are obligate nose breathers. You have to be able to breastfeed. If you can't, I mean, what's our colloquial term for people that aren't very sharp? Mouth breathers. Okay? Wonder how that happened. Everything is shifted slightly forward. And it's not really, there's no abnormality, you'd say. The term we used to use was FLK, funny looking kid. And that would mean we saw something funny about the facial structure, but we just don't know what the heck it is. Do they still use FLK? Okay. Yeah, because it's like I got an FLK here, and then when you're a sleep doc and they say that on the phone, it's like, you got the first appointment tomorrow. The problem is here, their airway is more cone-shaped. Now, subglottic, here's the problem. It isn't a tube, it's a cone. And it's just the way that their airway moves down. There's the comparison. There's a bunch of laws in physics. Poiseuille's law, which we'll try to get into, but I didn't know how to spell. And Bernoulli Effect, where air movement is high, pressure is low. Take two pieces of paper and hold them between your fingers and try to blow them apart. They don't. They suck together. Okay? You have to understand that. As you increase velocity of air, pressure drops. That's why a wing lifts up. It has longer range to go over the top of a curved wing, so it pushes the wing up. That's thrust. So the Bernoulli effect. Air movement is high, pressure is low. So what's going to happen right here when you take that much air and make it go through that small an opening? Velocity increases. Thus, your airway and the tissues around it are going to collapse normally. The strange thing I found out about this is, and we'll get into this in a second, the highest area of resistance is not right there in the upper airway. The highest area of resistance is in the peripheral lung bronchioles. Okay? That's your area where you're really fighting to get them to breathe. Well, what's going to happen if you make things narrow right here? Their highest area of resistance, lowest area of flow, is out in the lungs. And you're going to suck more air through. Look at the angle here. Remember when we put a dental device in? We want to pull it kind of this direction. Okay? The vector is out here. Pull the tongue out of the way, separate the teeth down, forward. Well, look in a kid. Okay? We're going to squish everything back this direction. And we're going to kink it all right here with a great big floppy head. Okay? What happens when you bring the child home from the hospital and you hand it to your 6-year-old? They don't support the head. Okay? So, is this a problem? Oops. Is this a problem? Huge. Smaller airways, higher velocity flows. You're not going to see these changes until a ways down the road. Why would this happen? And this is kind of weird stuff. If you're familiar with Jared Diamond's theories on how we colonize and why some Guns, Germs, and Steel, he got the Pulitzer Prize for, how we colonize different areas. One of the things he and Terrence Davis at UCLA did was said, we were able to evolve because we could speak, what they called the Great Leap Forward. So what this is, sorry, I keep flicking the wrong buttons. This is a human with a human face and a human skull. This is a chimpanzee with a chimpanzee face and a chimpanzee skull. Then they said, okay, let's take a human and put a chimpanzee skull, high forehead, looks like Cro-Magnon. Small brain. Interesting. This is Homer Simpson. Not really. This is an ape airway with a human brain. Okay, maybe it is Homer Simpson. But the whole thing is, look at the size of the airways here. They're supported, except when you have the combination. Upright posture, okay, rotated the pelvis forward, we're walking, we're keeping our head up. We can travel large distances because we need to feed large amounts of protein to a large brain. So all these changes make sense. Now, why do we have sleep apnea? Because it's more important to have abstract communication. Don't go over there because there's people that eat you, okay? Rather than having an airway that stays open. Chimps can make about 400 different sounds. We can make 4,000. Nice airway in chimps. I don't know if they have sleep apnea. I ain't going to hook them up. It's hard enough to hook up children. Infant upper airway resistance. Okay, upper airway show that peripheral airway resistance in children younger than 5 years of age is 4 times higher than adults. The major site of resistance is in the medium-sized bronchi. You're getting way down through the trees of the branches before we encounter the greatest area of resistance. So if that kid's got his head kinked or there's problems breathing in the upper airway, it is magnified directly fourfold. And that's important. Now here's my math slide. And this is slightly blurred because you can do that now. And I don't really care about this because I don't know how to spell Poiseuille's and I'm really bad at math. What you need to know is, put more simply, if the diameter is decreased by half, the resistance to flow increases 16-fold. That's huge. Okay, why do you use a large bore needle if you want to put lots of stuff in fast or take lots of stuff out fast? Anybody here use a 16-gauge needle to inject with? I hope not. Okay. The lumen diameter is smaller, leading to greater proportional level of response. And here's the math. Pediatric airway, 1 millimeter layer of mucus. About like everybody has today because there's all the garbage in the air out there. You hear how you're breathing. Little tiny bit, 1 millimeter. Well, in a 4 millimeter airway, you've decreased the radius, so the diameter is decreased by 2. Now you have a 4 millimeter airway decreased to 2 millimeter. The small ones, 16-fold decrease. In an adult, same thing. 2 millimeters from 10 to 8. That's only a 2.4-fold increase in airflow resistance. Just because they're smaller, they can't move air as well. Plus, you've already got a glottis that's sticking and small. Does head position matter? Of course. If you're trying to intubate a kid or work with them when they're trying to die on you, that is the most critical point. But we don't think about that when we sleep at night. What position does your child sleep in? Any position they possibly can. Upside down, face down, butt up in the air, legs up on the wall. You just wonder how they even survive. But think about what the airflow, how bad is the airflow. Parents will come to me and say, what do? We can't get him to sleep. He keeps waking up every 15 minutes and he's just irritable and can't breathe and he's got sinus problems. So we're going to send him to an ENT specialist. Is the roof of the mouth supposed to be flat? Okay, because that's what I was told. I know I've talked to a lot of you guys and I always ask that question. Yeah, there's got to be some curvature to it. But we say, hey, if there's curvature, it presses up on the septum and then the septum bends and then they have bad airflow through one nostril. What's the main cause of a deviated septum? High arched palate. They didn't get punched in the nose when they were a kid. Okay? That's a big deal. That's something where a dentist needs to be talking to a doctor and say, no, this is normal. I showed a colleague a picture, and I said, this is a really bad airway. And she's going, no, it doesn't look bad at all. There's lots of places to put stuff in there. I was given, this is from Clementi. This is one of our main atlases that we use, especially for vascular and upper and head and neck anatomy. Okay? This is supposed to be flat. And they said, look, right here, this is flat right here between the molars, so your roof of your mouth is supposed to be flat. Otherwise, it'd bend the septum. Turns out that's not true. What I always like is, see how nice and flat and square this is? How many times do you open a person's mouth up and their tongue's all scalloped and it hangs out and you can't even find the teeth because there's a big pink thing in the way? And I thought, I don't think that's normal. It's real easy for us to see that in Down syndrome. If you see a Down's kid, they have a protruding tongue. Okay, well, we see this all the time and you can't really figure that out. It just isn't as prominent if their jaw is back only a centimeter or so. And that becomes much harder to recognize. So, septum's supposed to be straight up and down, flat roof of the mouth. They proved it right here with a picture. Diagnosis, how do children sleep? Any way they can, and all the time, and at the least opportune moment for you. All children who snore should be evaluated. That's from the American Academy of Pediatrics, 2002 paper. I don't know that they've updated that. How do we get people taken care of? How do we get people diagnosed? We need a sleep specialist, ENT, a pediatrician, a dentist, and we need to apply a systemic approach. We need to have everybody working together. You send me a patient, I'm going to say, well, that kid's got giant tonsils or a messed up airway, or they're really acting abnormal. That's hard to tell in children, I know. But that's what they come in with. Those are your three major complaints. Get your team together. This is where you hang your ego at the door. Get people working with each other. You go out and you make this happen. That's your job, because nobody else has been doing it. Whoever makes the primary diagnosis needs to pull the team together. That's just a given. Okay? This is where you don't, if somebody doesn't respond to you or say you don't know what you're talking about, I think I have this kid who's got giant tonsils and can't breathe and is acting really weird all the time and is having problems in school, and if your sleep doc blows you off or tells you you're an idiot, hang up. Go beat him up if he's smaller than you. Really, you gotta, we're all colleagues. All kidding aside, we should be all treating each other correctly. And you say, this is sleep apnea, I think. I need an adequate diagnosis here. Where should we start? Okay? Whether you send them to an ENT specialist, sleep specialist, it doesn't matter. The whole thing is pull the team together. Hang your ego up at the door and get the team working on it and say, where do we go? Every single practice parameter, and I have the pediatrics and I have the adult ones here. You can go on American Academy of Sleep Medicine website, American Academy of Pediatrics website, American Dental Sleep Association website, and they have those two practice parameters on their website. I printed them out yesterday morning. They have all the details. I've got copies here if you want them. If people can make copies of the stuff. It's very important. The parameters go over every little detail you follow, and that applies to every discipline, not just doctors, not just dentists, everybody. Is this an easy one to figure? Pierre-Robin syndrome, very small. I mean, where's the chin? Unfortunately, he's already been treated with the old way we used to treat this Pieroban, you do have to trach them sometime. Trach didn't look so bad, you know, a long time ago when people couldn't breathe. Then we developed Cpap, and everybody said, wow, trach sucks. And then they developed dental devices, and now everybody's going, Cpap sucks. And nobody does trachs on them unless it's a major malformation. Is that a bad roof to a mouth? A bad palate? Now, if you send this to me, I'm going to go, oh my God, because I haven't learned dentistry very well yet. And I do sleep studies, and if you send somebody to a guy with a knife, he's going to say cut. Okay? Don't be surprised. Anybody who looked at this, any doc would look at it and say, pretty high. I did. That's why I included it. Evidently, it doesn't make you guys worry at all. How about this? So the airway is comprised of this two little bubbles right here, which may be gummy bear or something, I don't know. This is a problem. Looks a little bit red, okay? So I'm going to say they might be infected. A little bit of exudate along the edge here, redness, because they suck on their uvula, okay? This is the one you guys see and you send over to me and you go, whoa, what do we do with this? It's amazing the range of tests you can get from a kid like this. They may breathe fine. And I just look at it and go, no, I don't want to deal with this. My recommendations are 1 apnea, and this is true for most insurances, 1 apnea in a child under age 5 is severe sleep apnea. Take the tonsils out. Some people say, well, it's 1.5 to 2, 2.5 to 3. Calgary Children's Hospital in Alberta has a different way of doing it. Madeline Greg Danvers information. The basic idea is if there's at least 1 apnea per hour, you can get the tonsils taken out on a kid under 5 years of age. That's important. I don't like tonsils this big. Do you think this is a compromised airway? I don't care if the insurance company doesn't think so. I think that's a compromised airway. They need the tonsils taken out first. That's the recommendation. And if you read them, that's what it'll say. And 65% of the time, they're fine. You'll remember, though, right before Christmas in Chicago, there was a little girl they didn't want to take off the ventilator because it was Christmas time because she was brain dead. And the hospital said, she's brain dead, but she bled out and her brain's fried. What was she in the hospital for? A routine procedure, they said. Turns out that routine procedure was taking tonsils out for sleep apnea. Is it a risk? Yep. Like I said in the slides earlier, always think worst case scenario. That's why the word death appears on every drug handout. And that's why when we talk with our patients about something as drastic as taking tonsils out, what's right underneath these, right along through here? Carotid artery. If you go a little too deep, it gets real exciting. They're at the University of Chicago, top people in the world, every emergency team that could have worked on this little girl. Still brain dead. Can bad things happen? You bet, and you got to anticipate them. Always think worst case scenario. Treatment. Is this compliance? This little girl's so happy. You can tell that she loves having this stuck to her face. And that's why they put her little angelic face on the ad and said, this is what I really wanted in my life. And you can switch the tube to either side because that's what children are concerned about. More appropriately, this guy. He loves this. You get a couple of Sharpies and make a Spider-Man mask out of this thing, he'll never take it off. He actually started off not liking it, but he did very well, I was told. Probably with the Sharpies. I don't know what these are for. You put them in your mouth, evidently. And I've heard all sorts of stories. There's how many different oral appliances? There's like 12 or like 190. The FDA just approves them if they go in your mouth, I guess. I don't know what the criteria are. But nobody has been turned down that I've heard of. So, which one do you use? You know, it depends on the practitioner. I don't really care as long as it works. It's like a Cpap mask. What is the best Cpap mask? None. Not one of them uses it. Not one of them likes it. Okay? Do they fit your face? I tell people when they come in, they say, what is the best one to use? I say, none. Duct tape and a garden hose will work. Seriously. And it's like a pair of shoes. Whichever fits is what you need. Is their airway changing? You bet. It takes about 100 days for the airway to change, biochemistry, anatomy, and physiology of the airway. So that what you start with is not the pressure or the airway you're going to end up with. It's very, very different. Get them on something. If you can keep them on it for 100 days, which is no mean feat. And every one of them asked me about the second or third visit. I remember you said something about a dental device. And it's like, okay. I have hundreds of people that need them, but they have to work correctly. What do you do afterward? You get this team rolling, and you get the Cpap diagnosis or take the tonsils out, and you need further intervention, either on an adult or a child. Recheck them. You'll see this in the parameters all the time. How many people recheck them? Nobody. The first set of dental devices I had made when I got to Hermiston, 6 dental devices, decreased 1 apnea. Guy went from 60 to 59. None of them worked because there was a disconnect between the dentist and what they thought I was looking for, what we were trying. The patients were telling them, we want to treat primary snoring and not sleep apnea. And the guidelines make that differential. We just don't think that way sometimes. That's why the collaboration is needed. Good communication and a team approach. And this gets real easy. And once you start cranking out dental devices that work, people will flood your office. And that's the idea. Right now, we're working with several of you on getting the reimbursement. That's a big problem. People don't want to pay out of pocket because they think, well, it's a medical problem. I don't need to pay for it. Dental problems, they'll pay for. Okay? The insurers look at it the same way. If we can get them in this area, if everybody sends in and says, listen, this is the way this needs to be treated. This person doesn't want to use Cpap. Okay? Lady came in and said, I won't even try it. I'm going to get my dental device made. She got the dental device made. Took too long, so she came back. Finally got her dental device made, or her Cpap on and everything. She used it 3 days and came back and said, this sucks. And we put her back on her dental device, and she goes, I hate this less than I hate my Cpap. Good. I got a success. She's using her dental device, and it looks great. Good compliance. You've got to work with the disease, you've got to work with the patient, and you've got to work with the damaged airway. That's hard. Does it help to have a collaborative group? You bet. And this is where the success is going to come, when you go out there and put together a team. Some other weird stuff. TURD, TRD, tongue retention device. Don't put a turd in your mouth. I have not successfully treated anybody with this just because it gives your tongue a hickey. I don't understand why you need lateral motion with something that's going to lock your jaw shut. Is that a thing that you need? I don't know. See, these are questions that we have. If you want somebody to be adherent to a dental device or Cpap, Show them this first. Maxillomandibular advancement, otherwise known as BIMAX. What they don't ever show on the pictures is from right here, there's all the nerves and veins and arteries that you have to go over and around with the saw to get that cut made. This is 5.5 hours of trying to mess up a person's face. The guys who developed it, Riley and Powell, are good friends of mine. I've done a bunch of these with them. And the entire procedure is just nerve-wracking. If things don't work, we can go this far, and this will cure them. That's a lot. That's not your first choice. So yeah, just show them that. Men don't want to come in. Somebody was asking me earlier, how to get my husband in. You tell them, it hurts vascular beds. Heart, lung, kidneys, brain, penis. The first 4 don't matter. Okay? Lastly, obesity. 2/3 of all Americans are overweight. Okay? That's impressive. If you have a BMI of 50 to 60, it decreases your lifespan by 20 years. This is big. Number 1 cause of death the last 4 years, 5% more than smoking. Isn't it cool? You don't, I mean, look at an old, we used to do this in public health. It's a drinking game, actually. Somebody gets an old copy of Dragnet, and every time one of them takes a drag on a cigarette, you got a drink. Don't play that game. Okay? People used to smoke everywhere. We've really made a dent in that. We've really hit that disease and hammered it down and done a fantastic job as a society. We can do the same thing with sleep apnea and the problems inherent with all this, and getting people breathing and taking care of the vascular problems. But you've got to start somewhere. 26 million type 2 diabetics in America. How do we intervene? Dietary. We were taught that if you wanted to cure obesity and sleep apnea in family medicine, all you have to do is get your patients to lose weight. That's simple. How well do we do there? Cpap does help. Surgical does help. If you can catch a guy first 2 or 3 years that they have insulin resistance, which you've heard, okay? If you can get them early, get them on surgical track, put them on Cpap so their airway doesn't collapse while you're doing surgery on them, okay? They're going to get the dietary counseling they need. They're going to be watched closely. They're going to have a multidisciplinary team watching them. You can decrease diabetes down to 1 to 2%. Most of these people don't need anything if you can get them down to normal weight and hold them there. That's one of the big things I think will come out of Cpap is holding them at that weight because the metabolic drain is not still there. Can you do that with a dental device? Yeah. Lady comes in 2 days ago and says, okay, I'm going to get my lap band done. Great. She's got 6.7 apneas per hour. We don't treat until 5. So she's barely into the mild range of sleep apnea. She says, I don't want to use it. Do we give up on her and say, okay, well, you can't have your surgery? No. Hey, how about a dental device? Maybe we can control you with this. We'll heal your airway up. We're going to send you over, have the dental people look at you, fix you up, send you to the surgeons, get the weight down, fix all this other stuff. Multidisciplinary approach. Hit it from multiple angles, stabilize the patient in a macro setting. You don't have to get labs. You just got to be convincing. Multidisciplinary approach, interventions are 83 to 90% are completely cured. That's obesity surgery. I mean, I used to think that this was voodoo. You don't do that kind of stuff to people's stomachs. Now it's one of the biggest areas that we're looking at the insurance people covering. If we can get them to cover this, then why won't they cover dental devices? We need to work together on this. How am I doing for time? How far am I over? Like an hour? Okay. Watching practice parameters. For adults, they were written in 2005, have not been updated. Peds, they were written in 2011, which is a little better, and published in 2012. Okay, they differentiate primary snoring from obstructive sleep apnea. I can't do that very well. Snoring is moving air. Apnea means no breath. If they have apnea, are they breathing and snoring? No, but why do so many people have the same thing? Because they snore, and then in between the snores, they quit breathing. We get caught up in the way we address things. Take the tonsils out first, always. Follow these patients. Children with a higher preoperative AHI are going to need further treatment. Kid comes in, he's got 6 apneas an hour. Take his tonsils out. Mom says, you know, we're going to come back in 3 months, redo the PSG, the sleep test, and the apneas went up to 9. What happened? If you look at the sleep study, the first sleep study, he had no REM sleep. The second sleep study looks like perfect sleep. But the number of apneas went up. So did we succeed? I told her come back in a year or 2. Her response to me, and that's one of the biggest things, critical evaluation from maternal observations. I tell them before they leave, he's got sleep apnea, we're going to take the tonsils out. 3 months after the tonsils are out, okay, you're going to bring back the book that you write down every day, how much different this child is. Observation. It's a real archaic way of looking at humans. Okay, the moms come back and go, whoa, kid's completely different. Sleeps through the night, doing better in school, not as cranky. It's not like waking up a badger in the morning. Really. Cranky 4-year-old is something to be contended with. So ask and document that. That's important. Do numbers matter? No. We don't treat numbers, we treat people. Broad range. When you look at pediatrics, palatal expansion. How many people here do palatal expansion and stuff? Is that all orthodontists? General dentistry, they don't do that, okay? But dental devices, yes. Okay, dental correction, monitoring just the stability of the oral airway. Orofacial surgery, yeah, we can go and do some things. Pierre-Robin syndrome, malformations and deformations. Yes, we can make significant inroads there. Extreme cases, but that's okay. Tracheostomy, again, severe cases such as we saw earlier. Cpap, I'm not a fan of putting Cpap on kids. It's hard to keep them on. There's a few people, kids with Down syndrome, that you can get on there if they're completely out of it. And even though they may have severe mental deficits, bedridden, wheelchair-ridden, no neurocognitive parameters that you can function, getting them a good night's sleep drastically improves how they function. As little as it may be, their function improves. Do not count them out just because they're quote-unquote damaged. Ask the caregivers. They'll report wonderful things. That's what we're going for. Advanced surgical intervention? I don't know. Yes, that's always available. The parameters, we'll discuss that. But I would go down the road a ways before I tried that. Okay, thank you and good luck. Your patients need all of us to do this better. Do I have time for questions? A couple? Any questions? Yes? Pardon? I'm going to walk up here. I only do it up to age 5. After that, they don't heal as well. We don't see as much change because the airway has solidified. It's not moving forward as well. Do some of them work? Yeah, I had a 6 or 7-year-old that's doing well when we took the tonsils out. I think things are stable. Try to take the tonsils on a 21-year-old out, you'll kill yourself. More questions? Okay, thank you very much.